Well, let me illustrate a case here and show you how the synthesis of the carpentry and the biology comes together, and how an Osstell, or understanding the ISQ, helps us make decisions. This is a patient who's been in my practice a long time. She's 78. She's been on bisphosphonates, has very large mandibular tori, very limited mandibular opening because she has some degenerative joint disease. So she only opens about 15, maybe 20 millimeters total. She's got resorption underneath the crown on a lower first molar. And on top of that, she has fairly poor mandibular bone density. So the question is, what do we do with her? She wants to replace this tooth. She has ample funds, and she wants to do something. So we did a flapless extraction, very challenging, but managed to get the tooth out and the socket, leaving the socket intact. I grafted the residual socket with autogenous bone chips plus demineralized bone mineral, and placed an implant in what I thought was the septum. Turns out it was more towards the mesial socket. And when I finally put the healing abutment on it, I was able to relatively easily rotate the implant with the healing abutment. So I'll ask you for the first question. Let's do some voting and try out our system here. What do you do? Marcus, you have?
Yep. Switch.
So what do you do when you place this implant? It rotates with the healing abutment. Do you remove the implant? Do you remove the implant and graft the socket, or do you leave it alone? Let's have some voting on this. I want to hear what you're thinking. It's either one person or you're all geniuses. I know what my residents would do. My residents think like carpenters, and they think that they like to deal with holes. And dentists, by nature, we are trained to fill holes. And I would like to argue that that may not be the most appropriate. Okay, let's move on. So, decided to leave the implant. 1 month post-op, there's no radiographic changes. It's kind of a miracle we got a periapical radiograph, but we did. At 2 months, again, there are no real radiographic changes. The implant seems stable, the little that I can manipulate it. And then she goes a few more months, and now her, at 5 months, she has an ISQ of 43/47. Let's vote again. What do you do? Do you take it out? Do you take it out and graft the socket? Or do you just leave it alone? We have similar distribution, probably a few more remove it and graft. Okay? Okay, let's go back. So we leave it a little more time. And then at 6 months, it's now at 60/60. And then at 7 months, she gets restored. What does this illustrate? It illustrates the healing potential of bone. It illustrates the ability to monitor the healing process and to infer what's going on the bone-to-implant contact side. And it allows us to use non-invasive monitoring to get a success story out of this patient, out of this very challenging implant.